Good morning and welcome to Ohio Women in Government's May webinar. I would like to say a special thank you to G2G Consulting for sponsoring this event. We're so glad to have you as an ongoing supporter of Ohio Women in Government's programming, from helping us launch our Cleveland chapter to an ongoing webinar series. Today's topic focused specifically on women's health policy. We're thrilled about our panel coming together this morning. I'm Brittany Bolton. I'm Ohio Women in Government's president. This is my final year as president. I've been involved with the organization for about a decade, and it's been one of the greatest joys of my career to help convene women who are interested in government and in government adjacent careers. Ohio Women in Government, for those of you who don't know us, is a statewide, nonpartisan, nonprofit organization. We are completely volunteer-led and very proud of that. We are run by a volunteer board of really fantastic ladies and some chairs focused on various work and programs that we do around the state. We run a scholarship program for women who are entering careers in the Ohio State House. We also offer monthly opportunities to network, to engage, professional development, and to hear great speakers and experts like today's policy experts. Finally, we are launching chapters around the state next month, or later this month on May 21st. We will be in Chillicothe. I'm really excited to come to Ross County and continue expanding our footprint into Southeast Ohio. Stay tuned for an upcoming event in Columbus, a morning networking coffee that we'll be announcing over our listserv. If you go to ohiowomeningovernment.com, you can go ahead and sign up for our email alerts and make sure you don't miss any events with us. I also want to say a special thanks to our steering committee who puts together all of our events and helps with a lot of the back end programming on everything. Another housekeeping note, you will want to enter any questions into the Q&A box of the webinar chat. So thank you to G2G Consulting for womaning that chat. And we'll make sure that we get our Q&A up and going as soon as our speakers begin. Before we launch into our panel, I want to introduce my friend and mentor, Liz Powell, who will hop on screen here any moment. Liz is the founder and principal of G2G Consulting and a really passionate advocate for women's health. And I would love to welcome her to the chat. Good morning, Liz.
Good morning. Thank you so much for kicking things off, Brittany. I have to say, Brittany and I go way back. I had the pleasure of working with Brittany for several years, and she's done an amazing job with OWIG, inspiring so many women to pursue this field of government affairs and to excel in it. So it's just a great organization. G2G has been super excited about our partnership and working together to sponsor events in Columbus, online, and in Cleveland. And we've done more and more in Cleveland recently that we're super excited about. So I'm Liz Powell. I am the founder and head of G2G Consulting, which stands for Government to Growth. I started G2G in 2007 after working on Capitol Hill as a legislative director. And I did a lot in health policy and women's issues, defense, business, a lot of different issues actually, but a lot in this space in women's health. And we've continued to do a lot at G2G in this area. And so we were really excited to team up with OWIG to do today's event. At G2G, we do government affairs, federal, state, local level, and we do a lot in Ohio. We're in Cleveland, Columbus, and DC. And we've raised $528 million in government funding for all kinds of organizations across the country, not just Ohio. And we have found these partnerships with government to be really valuable. So whether it's policy drafting, state house days, fly-ins, regulatory impact, all kinds of events, we think that connecting people to government's really important and really makes a difference. So today, we're focused on women's health in particular, because what we have seen over the past few years is a ton of work happening in this space, whether it's in innovation, research, entrepreneurship, nonprofits, advocacy, members of Congress, state legislatures, governors. There's just a lot more interest now in women's health. And we see it not just as a moment, but a movement. There's a movement happening across the country that we want to turn into a mandate for change. And Jamie, my colleague, is going to share some great background on why there are these significant women's health gaps to really explain why this movement is happening. And what we're trying to do as far as creating a mandate, we've launched some amazing organizations, one of which she also is going to cover, but it's the Women's Health PAC. And I hope you'll all be engaged in that. It is bipartisan, nonpartisan, all about those broad women's health issues that's really affecting all of us, because all of us, we've all been a patient. We are patients, and we're all feeling gaps in the system at times, or we know people who have. So with that, I would love to introduce Jamie White. Jamie White is an amazing leader in women's health. I actually had the pleasure of working with Jamie over the past few years in her previous position at the Office of Research on Women's Health. She led a new initiative there called the Innovation Equity Forum. It was a partnership between NIH and the Bill and Melinda Gates Foundation. And she took this from 0 to 100 in amazing speed and effectiveness. And they came out with this huge roadmap for what we need to do to address women's health gaps. It has really shaped the national dialogue in addressing women's health. And so we are just thrilled to have her now at G2G. She is a government affairs manager and then the director of women's health for G2G. So I'm so excited to introduce my colleague, Jamie White.
Liz, you give the best introductions. Thank you so much. I really, really appreciate that. I'm here to talk to everyone. And again, good morning, Ohio, and those who maybe are not in Ohio, but I wanted to give a special thanks to the organizers for allowing me the space to kind of talk a little bit about women's health and specifically thinking about it from a national overview. Before I get started, I first want to thank the mothers for all the work that you've done. It was Mother's Day last week or yesterday, and so just wanted to say happy Mother's Day to all. Whether you are birthing of a child and or if you were a godparent, a sister, you are part of a village of taking care of the nations or babies in these days, I really just want to say happy Mother's Day to all of you. But I want to level set just a bit. When we think about women's health, I think it's important to think about it from different perspectives. There was an old paradigm when we're thinking about women's health, and it oftentimes just thought about reproductive issues in breast, or sometimes coined as bikini medicine, along with thinking about maternal health and infant health. And there's also was a focus on how women were specifically different from men, but that's somewhat of an older paradigm. And we're switching into a newer one where we're focused more on the health across the lifespan, thinking about from head to toe, and also thinking about mind, body, and spirit. And there's more of a focus in particular in the last several years on overall health and wellness. And then in addition to that, and thinking about sex and gender specifically and how that has implications and specifically impacts on the health and health conditions. So the way that we're framing it, and I just want to kind of put it out here, thinking about health conditions and diseases that are only in women, such as that of maybe menopause, that are mostly in women, such as something like autoimmune disease, and then something that might be different or present differently in women, such as that of heart disease. And we're going to be covering a couple of those topics on this call with the panelists, along with, I'm sure the patient story is going to hit on some of these things, but I just kind of wanted to level set as we're talking about women's health and making sure that everyone's on board with how we're defining women's health. So the agenda for this particular call and also for this important discussion, I'm going to just do, again, a quick national overview on women's health. Then there's going to be a patient story by Beth Ann, and she's going to follow me right after my slides. And then there's going to be a conversation on the new health value dashboard, along with panelist introductions. And there's going to be a panel discussion, then there's going to be Q&A, and then the organizers of OWIG is going to do a closing. So it's National Women's Health Week. This actually happens always and starts the first day of, it starts the first week or the second week in May, and it's usually in coinciding with Mother's Day. And so the first day is always Mother's Day for this. And I just wanted to let you all know the theme for this year. The theme is usually always led by the Office of Women's Health at HHS, or the Department of Health and Human Services, so everyone's aware. And the theme this year is empowering women, cultivating health, and again, celebrating voices, wellness, and resilience. And again, excited to be having a patient story because it's extremely important to make sure that we're uplifting those voices and also hearing them. Just so you all are aware, they're highlighting women's health issues during National Women's Health Week, and also talking about specific priorities. And so Sunday, the first day, they were talking about empowering women in their health journey. Today, specifically, is safe sexual health. Tomorrow is going to be shining a light on maternal mental health. Wednesday is going to be talking about reducing women's health stigma. Thursday is going to be understanding care. And then Friday is going to be reproductive health from puberty to menopause. Again, thinking about that life course perspective. And then on Saturday, we're going to be, they're going to be highlighting some work on women and heart health, which I think is extremely important to highlight, considering that's still the #1 killer of women, in particular in the US and actually in Ohio. And I'm sure you're going to hear more about that at some point. But I also wanted to just flag that there is toolkits. And so if you want to advocate for yourself and you want to also know more, please feel free to go to the National Women's Health website, or excuse me, National Week for Health of, excuse me, the National Women's Health Week website. And I have it coined at the bottom here. So please feel free to use that link. And they also, again, have a toolkit that you can leverage and use to learn more about these specific days. I also just wanted to quickly highlight, while we're talking about a national view, that there was a women's health initiative that was led by the White House, and specifically the First Lady, and it was launched actually November of last year. A lot of work has gone into a lot of the work that's going to be coming forth. But one of the big things that has happened in the last several months since this announcement is an executive order that was put out in March. And within that order, it talked about the different things that they plan on doing in this space, whether it be thinking about common data elements, whether it be, again, additional funding. There was a big splash around, and it was also in the State of the Union of $12 billion going towards this, hopefully in some way. And then in addition to that, I just wanted to quickly highlight that ARPA-H recently announced the $100 million that's going to be going towards this topic. And there's several people that have already applied. Hopefully we'll be hearing soon who those winners are for that particular initiative. But I think it's just important for everyone to be aware of these different things that are happening on a national level. But I also wanted to quickly highlight some legislation that I think is going to be important as we think through different things. And so there's recent legislation that just came out on menopause. And this is actually advancing menopause care and midlife Women's Health Act. And that's actually, for those who are policy wonks, that's the that's the HR 6749. There's also a recent bill that was just put out by one of your own Congresswoman Brown, for fibroids, and it's specifically the HR G247, and that is to authorize the Secretary of Health and Human Services, so again, HHS, to award grants to increase early detection of and interventions for uteroid fibroids, along with for other purposes. And another one of your own is Congressman Beatty. She actually just did some introduction of legislation with Congresswoman DeLauro to reduce the leading cause of death for women, which we just discussed. And also expanding Women's Health Heart Month services during Heart Month, which is in February. And I just wanted to also quickly highlight there's been a lot of movement over the last several years on the Black Maternal Health Momnibus. And so please stay tuned for the work that's going to be coming from that. And on that note, I just wanted to quickly highlight something that I know that's going to be just touched on a little bit later on in the conversation. And I just wanted to use this as a use case for health equity, thinking about the US maternal morbidity and mortality rates. Unfortunately, we are the highest when it comes to high income countries. And that's something that we don't actually want. That's not actually a positive. But I also think it's extremely important. If you look at the chart at the below on your left, it showcases that it's not just thinking about it on average for US, but there's huge disparities amongst Hispanic, US Hispanic versus US white, and then that of US Black women. And I just wanted to highlight, if you can see the chart at the end where it says 55.3, and you compare that to another country such as that of Canada, which is just our next door neighbor, which is at 8.4. I just think it's extremely important for us to really think about these issues and how we can mitigate them. And I'm sure, again, that the work that is happening with OWIG, along with the work that's going to be discussed shortly, will definitely hopefully highlight some ways in which we can fix this problem. But I also just wanted to quickly highlight some of the rates specifically for women have a chance of dying in childbirth twice as much as in other states. And so this is not necessarily just thinking about in totality. I think it's important also to understand that policies in states have really huge implications on what happens to the lives of those women in those states. And so I just wanted to quickly highlight this important piece. And again, you're going to hear a little bit more about that in the dashboard, I'm sure. And so I just wanted to end on thinking about how we can engage, or how you all might want to engage in women's health. There's a way to you can engage using and leveraging G2G. We're here for a resource, and I'm here as the Women's Health Director to be a resource to those who are a part of the ecosystem. But it's signing up for updates on women's health policy and funding, and you can use this website to do that. In addition to that, Liz, and along with 2 other colleagues, just started a women's digital health network. They actually just had a webinar last week on the launch for this event. The launch for this network, and I think it's extremely important for you guys to be aware of it. And similar to what Liz stated earlier around the Women's Health Pack, just wanted to let you know that there's a QR code if you want to know more information, and the QR card's going to the website. So with that, I want to make sure that I pass it over to Beth, and I want to thank everyone again for listening. And if you have questions, please feel free to put them in the chat, and I'll make sure I'll try to answer them that way.
Good morning. And I just want to thank Ohio Women in Government for having me in G2G. My name is Beth Ann Ennis, and I'm a wife, a mother to 4 beautiful children. I'm a caregiver of my 95-year-old mother. I'm active in ministry at my local church and my community here in Reynoldsburg, Ohio. And I am very passionate of walking with others that are cancer survivors. I have a passion for advocating for them, equipping women to speak and ask for the appropriate tools they need in order to journey in their battle against cancer. I also am a cancer survivor. I am battling non-small cell lung cancer, and specifically ALK positive non-small lung cancer. And I give you that specific because I'm going to share a little bit about my story and why that specific name, that gene mutation, is important to me. At the age of 48, what I thought was a strange muscle sent me to the ER, where it was discovered that something was significantly more serious. Nothing could have prepared my husband, John, and I to tell our 4 children that their mother had a mass growing in her lung that was cancerous. It was terrifying. I moved quickly into the surgery at the James Cancer Hospital here in Columbus, Ohio, to remove that mass and lobe in my lung, which was then followed by extensive chemotherapy and radiation treatments. 6 months later, my scans revealed there was no evidence of disease. But there was a critical moment I want to share that before I went into surgery, I was approached by a pulmonary oncologist researcher who asked permission to have a tissue sample of my tumor to perform biomarker testing for his research. And he said it might extend my life later. Of course, I said yes, my husband. I had no idea what biomarker testing, and I was in shock as a patient. So all of that information is just going in and out. But that biomarker test was taken in my surgery on my tissue sample. And it revealed that I had the ALK positive gene mutation. It's the rarest form of lung cancer patients. Only 5% of lung cancer patients have this gene mutation. And having this knowledge about myself was a blessing because there are 5 and now more in clinical trial successful targeted therapies that exist right now to treat my type of cancer. So almost 3 years ago, that into my journey, after being declared no evidence of disease by my team, my cancer came back with a vengeance, and I was diagnosed in stage 4 advanced. So now was the time, with the information that was taken from that biomarker testing, to turn to one of the targeted therapies identified by that biomarker test. Within 8 to 12 weeks of being on this targeted therapy, I had no evidence of disease. So from stage 4 advanced, 8 weeks later, no evidence of disease. So I have just been on this journey back to living life normally. And so there are so many benefits for me being on this targeted therapy directed towards the specific gene mutation compared to traditional means of treating cancer that many of us go through. I take my therapy orally. It allows me to be at home and be doing the things I'm called and love to do and be there with my family. I'm not in a hospital receiving traditional chemotherapy or radiation or having those horrific side effects. The side effects are not as hard as traditional treatment on my body. I'm active, I'm productive in the lives of my family members, friends, community, other women in my life. So it's given me the gift of time. Unfortunately, I cannot, or people with lung cancer do not go into remission when you have lung cancer, but targeted therapy will hopefully allow me and other survivors to treat our lung cancer and other cancers as a chronic condition. It is giving us time in which we hope to see a cure. So biomarker testing right now, it's not available to everyone. And without it, I would not have access to the targeted therapy that saved my life. I would not be here today if I did not have that targeted therapy. It's given me beautiful time with my family. I've seen some milestones I never thought I would see with my children, graduations, college, dances, all of that wonderful stuff we experience as mothers with our children. And so I've just been given this God-given gift of life-giving therapy, and I'm beyond grateful. So I really want this gift of biomarker testing for every human life that has to face a diagnosis of cancer. Biomarker testing is a life-giving resource. So we want to ensure that biomarker testing is available to all Ohioans. I've joined in with American Cancer Society Cancer Action Network. We are working on a House Bill 24 to help pass and get appropriate coverage for biomarker testing for all Ohioans. So a lot of different people, a lot of different resources of insurance do not cover biomarker testing. A lot of our rural hospitals don't have that access to biomarker testing. So as a woman, I highly, when I am walking side by side with women in my community that are battling cancer, that's a first thing I go into when I'm talking with them. Have you asked your doctor? Have they done a biomarker test? Because it's life-giving. So I just want to thank you for this opportunity to share a little bit of my journey and a little bit of what's going on in Ohio concerning this life-giving action. So thank you for having me.
Beth Ann, thank you so much for joining us today. I think having your personal story, which you were so generous to share with us, is so critical to grounding our conversation. For so many of the women on this webinar, I'm looking through the names. A lot of us work in public policy and advocacy at the state level or at the federal level. And I just really deeply value you showing the tangible impact of what policy can do. So thank you so much for sharing your story with us. And thank you to Jamie as well for giving us that great national context. Really excited about all the federal work that G2G Consulting is doing in the women's health movement and all of the gains that they're making and momentum that they're building. I wanted to introduce our moderator for today's panel. I invite Hailey Akah to join us this morning. We're still at morning. She'll be moderating this fantastic discussion. Hailey is the Vice President of Operations and Strategy at the Health Policy Institute of Ohio. And I'm very excited that she can give us a little bit more state context with the dashboard that they most recently released. I know I keep an eye out for it on my own inbox. So really excited that you can share that context before we dive into our panel discussion. Thanks, Hailey.
Thank you, Brittany, and thanks everyone. It's so wonderful to be with you. I'm going to share my screen here. Hopefully bring you all back up. Wonderful. All right, well, again, hello. It's lovely to be with you all. My name is Hailey Akah. I'm with the Health Policy Institute of Ohio. I have the absolute pleasure of moderating today's panel conversation. But as Brittany said, I'm also a researcher, I'm a policy analyst. I can't help but take this opportunity to frame our conversation a bit with some data from Ohio. So every 2 years, HPIO produces a data tool called the Health Value Dashboard. The dashboard contains data on over 100 metrics to create a comprehensive picture of the health in Ohio compared to other states. We analyze that data. We look for high-level findings about Ohio's strengths, Ohio's challenges when it comes to health, equity, and healthcare spending. And as Brittany mentioned again, we released the latest edition of the dashboard last month, and I'd love to share just a few things that we found with you. Ohio ranked 44th on health value out of the 50 states and Washington, D.C. Health value is a combined measure that includes Ohio's performance on health outcomes, on how healthy our population is, with what we're spending on healthcare. And after completing 6 editions of the dashboard, the story remains consistent that here in Ohio, people continue to live less healthy lives and spend more on healthcare than people in most other states. There are many factors that create this challenge in Ohio. Here, this pie chart is a way of thinking about that. Here we have the modifiable factors that influence our health. When many of us think about improving our own health, a lot of us think about our health behaviors, right? So we think about how we eat and how we move and how we treat our bodies. And you can see here that our health behaviors make up about 30% of what influences our health. We also see that 20% is clinical care. That's the access to the healthcare system, the quality of the care that we receive there on the whole makes up about 20% of what determines our health. And on the left, we see that 50% of that influence on our health comes from our social, economic, and physical environments. That's our housing, transportation, education, and employment outcomes. All those community factors that either help us make healthy choices or hinder our ability to do that. When we add on Ohio's performance on the health value dashboard, we see how we're doing in each of these things. Access to care has consistently been Ohio's best performing domain for the past few editions of the dashboard. This time we ranked 18th, so certainly in the top half of states. As we know, and certainly what Beth Ann's story illustrates, is that access to care is necessary. It's critically important. It's important when we have an acute or a chronic condition, when we've had an accident, if we're going to have a baby. But what this broader picture tells us is that while access to care is necessary, it alone is not sufficient for good health. These other drivers are also critically important, including things like the quality of care that we receive in the healthcare system, the capacity of our local health departments to do great public health programming, to the quality of the air that we're breathing, the food that we eat, how safe we feel walking in our communities. And in some of those other areas, Ohio does not rank as well. Here we see that picture sort of all together, those contributing factors leading to our health value rank. As we analyze the data from the 2024 dashboard, we identified these 4 policy priorities that can be used to improve our health value. Given the scope and the focus of our conversation today, I'm just going to briefly touch on that first one, mental health, and then the last one, opportunities to thrive. We see in the data that many Ohioans of all ages are struggling with mental health challenges. The rate of depression among adults has increased since 2011, and a quarter of adults in 2022 reported that they have depression. When we look at youth, in 2021, 43% of Ohio youth, these are Ohio high school students, reported consistently feeling sad. That in itself is a high number, but then when we look at these broken out by some disaggregations, we see even greater challenges for both female students and also students who identify as gay, lesbian, bisexual, other, or questioning sexual identity. I look forward to diving into the mental health topic a bit more in our panel conversation. Final thing that I'll mention, another finding clear from the data this year was that not all communities in Ohio have access to the resources, experiences, and environments that are needed to thrive. We talked earlier about the social, economic, and physical environments, those social drivers of health, some call them, things like housing, education, and employment that affect our ability to be healthy and make healthy choices. What we know from the research is that these conditions are shaped by some root causes, things like our culture, values, and beliefs, our institutions, and our policies. These root causes could either shape the environments that we live in a positive way, like creating greater access to healthy foods, for example, or they can inhibit health with factors like racism and discrimination that limit opportunities. There are so many examples that we can pull out of the dashboard that illustrate this point. But given today's conversation, I'll highlight this example related to food insecurity among children. We found that children with disabilities and children from families with low incomes and with less education are more likely to be food insecure. What this shows us is that underlying factors like ableism and poverty shape our environments in ways that determine which children can and cannot always afford enough to eat. Of course, this has impacts on families. Of course, this has impacts on the health of women. So in our conversation today, we're going to talk about the opportunities and challenges for women's health in Ohio. There are policy solutions to these challenges we face in the same way that there may have been policy causes to some of these challenges. I look forward to hearing from our panelists about promising solutions to these challenges that we're facing. With that, I'm going to stop sharing my screen and I am going to welcome our panelists, Dr. Maureen Corcoran of the Ohio Department of Medicaid, and also Dr. Deena Chisolm, who serves as the director of the Center of Health Equity and Outcomes Research at Nationwide Children's Hospital. She's also a professor of pediatrics and public health at Ohio State. And proudly, I'll say that Dr. Chisolm is chair of the board of the Health Policy Institute of Ohio. So with that, welcome both of you. Nice to see you, Deena. I'm going to ask Dr. Chisolm to introduce herself briefly and her connection to this topic of women's health. And then I'm going to ask her our first question.
Good morning, and thank you for that introduction. The only thing I will add to it, since it was very complete, is that some might say, why is a person who works at a children's hospital and does pediatrics research sit on a panel talking about women's health? And I think most of us know that there's a strong relationship between child health and maternal health and family health. And importantly, in a way that we sometimes forget, the health of women matters before, during, and after pregnancy, or whether pregnancy ever occurs or not. So as a person whose primary work focuses on the health of children, I can't focus on the health of children without really focusing on the health of women. And so that is how I get to be at this table. And I also get to be at this table because even though I'm a professor who does all sorts of fancy research, I love the opportunity to also be an engaged participant in the policy landscape. So as Hailey mentioned, I get to work with the Health Policy Institute of Ohio. I'm also a member of the Board of Health for the City of Columbus and a former chair of the Ohio Commission on Minority Health. So trying to bring the evidence and the practice together for health across our population.
Thank you so much, Deena. So Jamie framed our conversation at the top by framing women's health as issues that only impact women, that mostly impact women, or that differently impact women. And with that sort of framing and by that broad framing, I'd love to ask you, given your research and engagement in state policy, what trends are you watching in women's health? What positive trends are giving you hope? And or what challenges are you paying attention to?
So probably the trends that everybody is seeing, most starkly are policy changes related to reproductive health. And related to access to various types of care associated with reproductive health, and thinking about how those changes impact maternal health outcomes and birth outcomes and other health-related decisions for women and families. So, it's churning. So sometimes you hear something and it's really positive, and sometimes you hear something that's a little concerning, and sometimes you hear stuff and it's a lot concerning, but it's a constant focus on understanding how the policy landscape in the state and the policy landscape in the nation are going to impact the health of women of childbearing age, particularly during the reproductive processes. So paying a lot of attention to that. There's things that we've seen over the years that are really positive. We've seen drops in teen pregnancy, unintended teen pregnancy. So we know that we are doing things that are making or helping people make decisions around when and if to have children. So we know there are positive things happening. We're just also trying to figure out how everything changes as everything keeps changing. The other trend that I'm paying a lot of attention to right now is around the health systems and around access to care that are health system driven. So right now we're seeing a lot of closures of facilities that provide care for women, delivery hospitals, obstetric and gynecology practices are closing down, particularly in rural areas. And thinking about how we are adjusting the way that we deliver care to make sure that those closures are not exacerbating disparities faced by rural communities and communities of color. And thinking about what are the novel ways that we can deliver care in a way that covers those holes closed by closures, or how do we stop the closures from happening? How do we create a system where folks aren't closing down such systems? And when we talk about closures of facilities, also thinking about changes in providers. We're seeing fewer people going into practices like family medicine and OBGYN, which are needed for women's health. So how are we getting people into those? We're seeing fewer people of color going into those spaces, and people of color in medicine have a higher probability of serving in underserved areas and serving in primary care specialties. So how do we keep those numbers going? So those are just a handful of the things. And then just monitoring, trends. You said, what's good? One thing lots of good stuff. We're seeing fewer people are smoking during pregnancy. That's good. We're seeing reductions in breast cancer mortality. That's good. There's lots of good things we're seeing. And the other good thing that we're seeing is conversation. And even though conversation is hard, and sometimes conversation is uncomfortable, and sometimes it hurts, but people are starting to talk about all of these issues in women's health and women's ability to make decisions about all of the elements of their health, not just stopping reproductive, but broadly. And, once we actually start having these discussions, we can then start impacting the policies. So I'll stop there.
Great overview, and a couple of great topics that I hope we get to dive into more. With that, I'd love to welcome Director Corcoran to introduce herself as well and her connection to the topic of women's health before I ask her her first question.
Thanks, Hailey, and thanks to G2G for all of your work. So my name is Maureen Corcoran. I'm the director of the Ohio Department of Medicaid, work for Governor DeWine, and have been in and out of the Medicaid arena. Medicaid really is my passion, really now for more than 30 years. I'm also a nurse by training, and part of why that's important, not only in terms of who I am, but to this discussion is I'm not ever hesitant about looking at an individual circumstance, and I get a lot of emails and requests from help from individual people, and really enjoy helping sort that out and get them what they need. But I also am a devoted policy geek, and I fully confess and admit to that. So what I really have enjoyed in my work life is focusing on the healthcare system more broadly, and particularly Medicaid. And as probably all of you know, when it comes to Medicaid, in Ohio, in our case, we are predominantly managed care. More than 92% of individuals served by our program are in managed care. We pay for more than 50% of the births in Ohio. So about 3 million Ohioans are currently reliant upon our program. But no matter what metric we look at or any topic we touch on, we know that the issue, you cannot have a Medicaid conversation without considering the diversity and the equity and inequities that exist, whether because, and I really appreciate Health Policy Institute of Ohio's work on looking at equity, whether it's certain kinds of disabilities or whether it is race or ethnic considerations. It is pervasive. And so that is a lens, something that we are really trying to build into all of our programs and into all of our metrics. And I guess just finally, in terms of who I am, I had to chuckle a little bit when at the introduction here, when Jamie, I guess it was, said, we've all been patients. And I found myself thinking, you know, as women, we've all been patients. We also purchase more of the health insurance in this country than men do. We are all mothers and sisters and a significant part of the workforce. So for me, as a health policy person, it's a little bit of what about healthcare, as well as the social determinants and the environmental considerations we look at. What about that is not a place where women can do and should have their fingers firmly on the tiller? So I appreciate the opportunity to be with you today.
Thank you so much, Director. And so as we move forward to this conversation, Deena listed out a few of the trends that she's watching, that she's seeing in the research. In your work in the department, what are some of the challenges that are top of mind for you when it comes to women's health? And what is the department working to address in the current moment?
So let's see if I can highlight three things. One, I think probably many of you are familiar with the governor's State of the State address that occurred just recently. And I think that the litany that the governor went through is a really good starting point for this discussion. He focused the governor's State of the State this year focused exclusively and comprehensively on children. And to Deena's point, you know, how do you even talk about children or talk about moms or dads and communities without talking about children? He also talked about home visiting, what we're doing there, expansion of Family Connects, our Medicaid maternal and infant support program, the expansion of doulas, the comprehensive maternal care program that Medicaid has instituted, and we're looking at a more than 50% increase in this coming year with more than 138 practices. Our comprehensive primary care for kids practices. We have now more than 1 million children enrolled in our CPC program, school-based healthcare, and some expansions that were included in the budget in our work. Behavioral health care, the governor talked about OAK. I want to come back to that a little bit. He talked about crisis services in communities, especially for children. Ohio Rise, behavioral health services for our most complex and multi-system kids. The Great Minds Fellowship, encouraging and working on the pipeline of behavioral health professionals and practitioners. He talked about dental care and vision care and telehealth. And that, you know, topic number one, or point number one, that's just what the governor highlighted in his State of the State. And what I found as I worked with him and others in the preparation of that is, this is, I think, is probably the first time that a governor has made their State of the State address exclusively about children and all these family and community issues. And he talked about the really hard issues that families face, not just poverty and, you know, kind of a general, but he talked about what it's like when you have a child who is self-injurious and you have to give up custody, or a disabled child who can't get childcare because childcare workers don't know how to work with a child who has disabilities. So a lot of good policy work going on there. Second, you know, Medicaid has only in the last year or two completed a reprocurement of our entire managed care program. About About $32 billion of our program is spent on managed care. Again, more than 90% of folks in our program are enrolled in managed care. And the hallmarks of that change, we refer to it as the next generation. And it's not just a good sort of marketing ploy. We kind of just found ourselves using that terminology because we really didn't want kind of an incremental improvement. We wanted a big step up on all these issues we're talking about. We wanted truly the next generation. And so there is a whole score of things that relate directly to this conversation about enhancing transportation in communities, additional mental health support requirements, after-hours behavioral health care access, increased accessibility for services, including things like language and other kinds of access. Investments in the communities, managed care plans required to invest some of their profit in communities, a deliberate, explicit commitment to individuals' health and cultural respect for people's health decisions, and really working differently around care coordination and with communities in what we call Care Guide and Care Guide Plus, as well as continuing and expanding a very significant focus on pregnant women and some of the infant and maternal mortality issues that Deena mentioned. And that's just kind of the highlights of this next generation. The third kind of high level thing I want to mention, and I hope we have a little bit more opportunity to delve into this, Hailey, is the healthcare system. And you know, as I mentioned, I love to help an individual person kind of navigate and sort out their problems with the healthcare system. But it is about really supporting providers who are caring for people and reforming the system so that it works better. And in that regard, the governor talked about, really made the public announcement about OAK, the Outcomes Acceleration for Kids, which is has never been done in the country that we're aware of, with our children's hospital, accountable care organizations, and all of our managed care plans in a very unusual partnership to really tackle some of the most significant health conditions, and with a focus on revamping the system. So again, later maybe we can talk about one of our examples having to do with the pregnancy risk assessment form and how we've used the science of quality improvement to really improve the access for pregnant women and getting them connected to care. So systems, rapid cycle quality improvement, tying innovative payment models and incentives together with those reforms, and in a really dogged partnership with providers. So that's a few of the things that we've been paying attention to.
Wonderful. Thank you so much, Director, for that overview. I heard you both mention that last point, Director, about healthcare system and innovation improvement there. I also heard Dr. Chisolm talk about health systems, closures, delivery in hospital. Let's think a bit more about what the challenges women are experiencing in the healthcare system itself. I've heard quite a bit about reproductive health, maternal morbidity and mortality. I've also heard quite a bit about mental health and challenges and interactions with the system. What challenges are top of mind for you, and what is like one key solution that you're looking to for one particular challenge you'd like to mention? And either of you can go first.
You know, a lot of what we think about when we're talking about people's challenges accessing the system tend to look at, you know, whether they have insurance coverage or whether there's a provider that is close to them. One of the biggest challenges is actually, do I feel safe and supported when I walk into the doors of a facility? And so a lot of the work that we've done with qualitative interviews of women, of moms who have delivered in the recent past, moms who have delivered in the less recent past, work that we've done and some research we're doing in the community of Linden trying to understand birth experiences over time, is that there are lingering challenges in people's feelings of safety and feelings of respect inside systems that were not really designed for them. And so for that reason, as much as we work on fixing the nuts and bolts, we also have to fix how those systems actually work and how the people in those systems interact with the patients who they serve. We talk a lot about trainings and that sort of thing, but we also have to talk about workforce. How are we creating a workforce that is aligned with the patient population that they serve, so that people walk into a facility, see people who look like them, who come from the community that they live in, who they feel have a connection to their own lived experience, to maximize the probability that they'll get good care, that they'll ask the questions that need to be asked, that they'll feel comfortable, the patients will feel comfortable offering the information that will help the provider do what needs to be done. So I think, from a policy perspective, continuing to focus on workforce diversification, continuing to focus on health equity, responsibility. So creating expectations and consequences of expectations when those aren't met are, a big part of how we're going to improve quality of care at the health system level.
And I can't underscore enough what Deena said. Tomorrow morning, I'm going to the doctor's with, I'll just say, a close person in my personal circle who has had a condition for more than a year. And this person has commercial insurance, educated, all that kind of stuff. But it's the voice thing. Now again, it's part of why my being a nurse is relevant. I've already now researched her entire medical history and written it all down so we can go over it with the healthcare professionals. But voice is so important in this, just feeling like you can make the point. So cannot underscore that enough. I want to give you two other kind of very concrete examples. One, as it relates to access, is we're coming out of the pandemic, of course, and as you know, finishing the unwinding, where we were required to maintain Medicaid eligibility throughout the period of the pandemic in exchange for federal money. And then during this year, since the pandemic ended, going back and redetermining everyone. And for those of you that are policy geeks, I want to just report that our most recent month revealed an ex parte determination rate of 89%. 89%. If that is, and again, I know for those of you that are really geeky, you're probably looking at me going, oh my God, that's incredible. It is incredible. And that's a really good indicator of access and facilitating access. The other final example I want to give you is one that I mentioned, and this is specifically to pregnant women. There is a form called the Pregnancy Risk Assessment Form. I'm sure those of you that are in the maternal and infant health area are very, very familiar with it. So I want to give you an example of what we're doing to try to transform the system through rapid cycle improvement and work between providers and payers. Okay, so this is just a tiny example or a specific example where one of the quality improvement objectives that we and the managed care plans agreed on for the 18-month period that ended last December around our quality withhold, as it's called, is the submission of the PRAF. And the importance of that, and speaking to the choir here, is that one of the primary uses of this pregnancy risk assessment form is that can be the very first time that the woman has an interaction with the healthcare system and kind of officially identifies that she is pregnant. And if we can get that information to the department, to the payers, the managed care plans, first thing we do is put something on the woman's record to make sure that she is not terminated from Medicaid. So make sure she's got the coverage. The second is that now, with a lot of the work that the plans have been doing and a lot of the work we've been doing around population health, the plans can reach out to her immediately, so that it isn't, 4 months, 5 months until we see a woman for the first time. Well, so here, working through this quality improvement, rapid cycle improvement, key driver diagram, creating specific metrics over the period that ended in December, we went from, and our objective was to get to 90% of all the PRAFs being collected and submitted as soon as humanly possible in the healthcare environment. Well, the results, which we're just now finishing up, are that we achieved the objective by 98.08%. In other words, we went from 330 PRAFs per week to 840 PRAFs per week over the course of this quality improvement project, using rapid cycle improvement and the science of change, working with providers and payers. And so in a very concrete way, that is an additional 26,500 women who throughout the year of 2023 were able to be identified much, much sooner and connected to care. Now, on the financing side of it, one last piece, we put innovative financing in place with all this work. And so for this particular project, $384 million was put at risk for the plans to earn if they achieved 100%. Now, they didn't quite get 100%, 98.08% of the goal was achieved, but we put serious money on the table to provide resources to fund the work, as well as to provide significant incentive. And the only way to develop that kind of change and to sustain it is, which the plans did, was get into the system, to talk with practitioners, to look at the workflow that's happening in practitioners' offices, to change the system so that we could get the information sooner and be able to move upstream. So that's just kind of a combination example specific to pregnancy, but also kind of giving you an illustration of the kind of projects that we have going on now, as similar with the Oak project I mentioned, where we're bringing more of this rapid cycle improvement with innovative financing to the table.
I'm so grateful to both of you for bringing your experience to the table to share with us, to tell us about the innovative things you're seeing in the research that you're seeing in practice. To close us out, I just want to leave us with that pie chart I showed before, that access to care matters so much for our health. And also there are these other pieces of the pie, our social, economic, and physical environment, what's happening in our communities sets the foundation for our health. And so for all of you working in the policy space in areas that are not health policy, you are doing the work of health policy too. And what you do matters for the health of women and for the health of communities. So thank you for being here. Thank you for engaging in this conversation around women's health and what we can do to improve. I'm happy to close this out here or invite either Brittany or Liz to say a final word to close us out today.
Thank you so much, Hailey. Thank you, Dr. Chisolm and Director Corcoran. We really appreciate your time today. I'll just note, I'll put in the chat, we've got Ohio Women in Government events on our events page. We have lots of events coming up, and we would love to see folks today at future events, both virtual and in person. Have a wonderful afternoon, and a recording will be sent out soon. Thanks again to G2G Consulting. Take care.